Hi friends, welcome back to Coffee with Ravi. Today my post is about what is bipolar disorder. Bipolar disorder is classified in the range of mood disorders and it's very common. And I think two take-home points right at the get-go is that number one, it can affect a fair amount of our population, and management requires a lot of patience, compassion as we deal with our friends, family members and patients who have this. The other point I wanted to make is suicide can be pretty common in this group of patients, and I wanted to raise the awareness of that to friends, family members that surround our patients and friends who have bipolar disorder. As we all know, as human beings, our mood fluctuations can happen even in normal, so-called normal spectrum. Bipolar disorder falls in the spectrum where the mood swings are so severe that they cause psychological distress and they cause behavioral and functional impairment. There's a manual called DSM, or Diagnostic and Statistical Manual of Mental Disorders, and that's a manual that is used by psychiatrists and medical professionals to classify these disorders, and this falls under that category. There's two or three main categories. One is bipolar 1, there's bipolar 2, and then there's a disorder called cyclothymic disorder. Bipolar 1 is where patients have manic features which are manifest by overconfidence, a feeling of grandiosity, a feeling of elation, less need for sleep, decreased inhibition. Whereas in bipolar 2, it's mostly depression, but there can be episodes of what they call hypomania, which is this kind of manic state but at a lower level. The cyclothymic disorder is where the symptoms can occur at a lower level, but it has to be there for at least 2 years. It's the 17th leading cause of disability, and it's pretty common. A lifetime prevalence in any one of us is about 2.4% and can sometimes be misdiagnosed as depression. As mentioned, the biggest risk is of suicide. About 6 to 7% of people who have bipolar commit suicide over their lifetime, so that's a big risk and we need to be on guard for that. A little bit more about the risk factors for suicide attempts in the group that has bipolar include female sex, younger age, minority race, bipolar 1, single or diverse status, predominantly depression, coexisting other psychiatric illness, cigarette smoking, obesity, prior suicide attempts, early life trauma, etc. These are within the group of bipolar, raise the risk a bit more. People with bipolar can also have associated medical conditions such as metabolic syndrome, where there is obesity, high blood pressure, high cholesterol, migraine, and also diabetes. Management includes general principles that we need to make sure there's no associated substance abuse, frontotemporal dementia, neurosyphilis, thyroid problems, anemia, and there's a syndrome called anti-neuronal antibody where the body manufactures certain antibodies against their own brain. Needs to be ruled out. Suicide prevention and aggression prevention are very important in the treatment. The treatment is antipsychotic medications and mood stabilizers. Different medications need to be switched around if there's no response. And lastly, bifrontal electroconvulsive therapy is selectively used in this condition. The drugs that are used in this condition include lithium, carbimazepine, divalproex. These are the brand names are Tegretol and Depakote, lamotrigine, and whether they're used when there's mania or depression depends on this table, and I won't get into it in detail, but you can look at the table that I have. There are other groups of medications which include quetiapine and risperidone, etc. Treatment of depression within the setting of bipolar, there's only 4 drugs which are FDA approved, which are cariprazine, lurasidone, quetiapine, and risperidone. There has been some controversy about using antidepressants because treating depression can push people into mania or hypomania. And as mentioned, electroconvulsive therapy can be used. Maintenance requires both psychosocial counseling, lifestyle interventions, working with the families, and the mainstay is medication. Lithium is quite commonly used, as is quetiapine. With the lithium, there can be thyroid problems, and calcium and problems in kidney issues that need to be monitored. Liver functions can go up with Depakote or Tegretol. Sometimes weight can go up, so therefore weight loss or weight and metabolic measures need to be kept in mind. So therefore, in summary, I think we need to make sure there's no coexisting conditions. Suicide prevention is important, and I think we need to give different attention to depression and mania, and then think about the surrounding aspects of the patient, including family members and their function as we manage this. Thank you for joining me. I know this is an important topic, and thanks for listening to it and helping with that in the community.